My title was Retroperitoneal Fibrosis, and just to kind of give you an idea how I fell into this, and seeing some old friends in the room, they know how I fell into this, but it was in the early 2000s. I'm a kidney doctor by training, and I was taking care of transplant patients, and a patient was admitted to Johns Hopkins, where I spent my first 30 years of my career, with masses in their retroperitoneum, and no one knew what they were. I didn't know what they were. And after hours and days of trying to figure out what to do with this patient who was literally dying in front of me, we guessed. And we came up with a cocktail that we thought would work based on drugs that we used in renal transplantation. And to my surprise, she got better. She had lost almost 170 pounds and was 60 pounds when I first saw her, and literally could not have the strength to get out of bed. That was in 2000, and I'll tell you, she's still alive today, and she's disease-free. And so when we were in medical school, we were always taught that fibrosis or scar doesn't go away. It's permanent. And when I saw this woman back in the office 3 months later, it was gone. And so we were somewhat shocked and amazed and didn't know exactly how to explain any of this. Well, one patient begets another, and as of today, I've accumulated over 475 patients with a variety of things in their retroperitoneum. What we have learned over these 20-some years is that there's more than one disease that looks alike on X-ray. And that's very, very confusing for physicians who may see this once in their life. And so patients come to me all the time, my doctor missed it or didn't know. I didn't know what it was either. And I now have the luxury of seeing only these type of patients, so it's very easy for me. But I understand for patients who've been misdiagnosed and shuttled from doctor to doctor, no one knows exactly what you have or how best to treat it. And people use words interchangeably that are very, very different. So what I thought we could do today is just go over some very basic things that I've learned over the past 30 years. And then we'll try to answer your questions based on your own experiences to see where we go from there. Well, retroperitoneal fibrosis, first of all, what's the retroperitoneum? What does that mean? Well, the retroperitoneum is a space. It is a space in your back. The only thing that's normally there are kidneys, and the blue and red there are your vena cava and your aorta, and there's nothing else there. And so when you look at a CAT scan, it's just all black. I don't think any of you have ever heard of a retroperitoneologist. There is no doctor who specializes in this space. And that makes it even much more difficult to try to find someone who could take care of you, because it's a rare disease in a space that no one owns. And that's part of the problem. So just to orient you, this is the kidney, it's part of the colon, and once again, the space here is where the vena cava and the aorta reside, and they become a very important part of our story as we move on. Well, what is fibrosis? We know what the retroperitoneum is now, and what is fibrosis? Well, in the most simple form, inflammation, which we've all had. If we've ever had poison ivy, we've had inflammation. And we know if we scratch the hell out of it, it turns to scar. So inflammation can either heal and go back to normal tissue, or it goes to scar. And when we look under the microscope, all this pink stuff is scar. And so pink is bad. And that's all tissue that should not ever go away, or at least that's what I was taught in medical school. It's there forever. So we have two words, retroperitoneum, it's a space, and we have scar. So what retroperitoneal fibrosis is, in its most simplest form, is scar in that space. What are some of the symptoms that people had? And probably many of you have had these. And so you probably know more about this than I do. But the things that I see most common are pain. And the pain's in the back because that's where the disease is. It frequently radiates down towards the groin, especially in men. People are exhausted. They've lost weight. I mentioned my first patient had lost 170 pounds. And so weight loss is a very, very common feature of this. If we look over all of my patients, the average weight loss is around 25 pounds before I see them. And so they're all convinced they have cancer or something else that's very nefarious. In men, because of the anatomy, they develop a lot of scrotal and testicular abnormalities. And so swollen testicles or swollen scrotums are very, very common. DVTs are clots in the legs. I showed you the vena cava and the aorta. The vena cava is the big vessel that takes all the blood back to the heart. When that's squished, the blood from the legs can't get back to the heart. And so it stagnates and forms clots. And so having clots in the legs is common, as is lower extremity swelling. Because the ureter, or the tube that takes from the urine from the kidney to the bladder, runs right through that space, as it's compressed, you can also develop renal failure from blockage of the ureter outflow. So these are all the types of things that folks can come in with. And because this turns out to be an autoimmune disease, like lupus or rheumatoid arthritis, patients also have anti-thyroid antibodies or autoimmune disease of the thyroid at the same time as they have the retroperitoneal fibrosis. So we always look for thyroid disease as well in these folks. I mentioned to you the spaces in black and grays. This is a CAT scan of a patient. Imagine they're laying on the table, the feet are coming out towards you, and the head is this way, so this is a slight right through the middle of the body. And all this should be black. This is the aorta, the white part, and all this gray stuff around the aorta is fibrosis. And when we see patients with these kinds of diseases, this is the first thing I want to see, is how much of that gray stuff is around the aorta, and is it involving the ureters? Ureters coming from the kidneys, and you can see they're surrounded by the same tissue, and it would be understandable why they could be compressed and you develop renal failure. It also goes down all the way to the iliac vessels, meaning your aorta comes down, branches one to the right leg, one to the left leg, and that's the extent of the disease. It goes from here to here. And if it's somewhere else, then I start to think there's something else going on. Here's an example of patients and why it's important. This is the gray stuff around the aorta, but these are the blood vessels going to the kidney. You can see how that could be compressed. And this is a patient who needed a tube put into their kidney to drain the ureter because their ureter couldn't do it. So it has significant impacts on the kidney. Well, retroperitoneal fibrosis, what causes it? As I said, when we started, we had no idea. We had no idea that there were 3 diseases that impacted this space. But as time went on, there's 2 populations and very good scientific evidence to suggest what's going on. The first is that people have plaque in their aorta. This is cholesterol. And people can develop antibodies to that cholesterol. So your body is viewing the cholesterol as being foreign, and your body's attacking the cholesterol. Where's the cholesterol? In your aorta. Where's the inflammation? Around your aorta. And that's one of the hypotheses, with very good scientific evidence, suggests that's one of the reasons why you develop retroperitoneal fibrosis, and it's only in this area, because that's where most of the plaque is. The second version is you have these tiny blood vessels called the vasa vasorum that actually feeds the aortic wall. That's the blood supply to the aortic wall. It's so big it needs its own blood supply. And there are cells that line that blood vessel. And the second hypothesis, or a second group of patients, is that you're developing an antibody reaction to those cells. Just like in rheumatoid arthritis, you develop an antibody reaction to the synovium, or in lupus, various other tissues. So one is cholesterol-based and one is autoimmune-based. We don't know in every patient which one is operative. Well, I mentioned that when we first came up with a treatment option for these patients, we tried to figure out what would decrease inflammation but not kill the person with the steroids. And during this period of time in 2000, the treatment for retroperitoneal fibrosis was 120 milligrams of prednisone a day for a year. And for those of you taking prednisone, that's not a healthy combination. In fact, the treatment is worse than the disease in that situation. So being a transplant physician, we said, well, we have several drugs that we use in transplant. Which one is the less toxic? And it was no more complicated than that, how we chose mycophenolate or Cellcept. Now, it turns out that CellCept has anti-fibrotic properties that we didn't know about. It actually induces an enzyme that chews up fibrosis. So we were really, really lucky. We were the right church and wrong pew when we prescribed CellCept for those patients. And that may explain why the fibrosis went away when we didn't think scientifically it could. But we didn't learn this until several years later, after we arbitrarily came up with this treatment protocol. The duration for most of our patients is 12 to 18 months. Now, one of the differentiating features between retroperitoneal fibrosis and IgG4-related disease is that IgG4-related disease responds really quickly. And if we see someone respond in weeks as opposed to a year, we start to say, this is a different disease, because this isn't the type of patients that we've been seeing that take 12 to 18 months for the fibrosis to go away. And that was one of our first clues that we may be dealing with a different disease in this subset of population of people who had IgG4-related disease. Well, just to give you an example of a patient, here's the start. A lot of gray tissue around that aorta. 180 days later, you can see that most of it is gone. We thought we had the wrong patient. I went down to X-ray and said, you mislabeled these films because this is not possible. And this is what we're seeing routinely. So we were very shocked at our initial response to treatment that we never thought the patient would ever leave the hospital. So after 23 years, for patients with retroperitoneal fibrosis, we have a 93% response rate. What does that mean? It means that if you have tubes in your ureters for obstruction, they're out. It means the mass has gone away. It means all of your symptoms have gone away. And so we're very happy with those kinds of results. And I see some graduates of our program here in the audience, and it's reassuring for me to see that now 20 years later, they're still doing well. About 8% of people do recur, and we have to treat them a second time. But we've never had a third recurrence. So that's very encouraging results. And we continue with this particular protocol for retroperitoneal fibrosis today. Not everyone who walks through the door read the textbook. And we refer a lot of people who don't quite fit what I believe the X-ray should show, or their symptoms should show, or their clinical course should show. And so if we took all of the patients that we've ever seen, which is over 500, how do they break down? Well, the majority in red have retroperitoneal fibrosis. A smaller part have IgG4-related disease. And that may just be selection bias, meaning that people send me retroperitoneal fibrosis and they send IgG4-related disease to rheumatologists. It doesn't mean that's a true representation of all diseases. There are a third disease that we discovered that also affects the same area, that is actually a form of cancer. But when we figured out what it was, no one knew what it was, and it wasn't a form of cancer at that time. And now we know exactly how it works, we know exactly how to treat it. And so all of these discoveries have come during this 30-year period. Well, sometimes things on X-ray are really what helps me figure out whether this is retroperitoneal fibrosis or IgG4-related disease. You don't need to be a radiologist to see that there's a lot of schmutz around the kidney. And you don't need to be any more technical than that. That space should be black. We mentioned in retroperitoneal fibrosis the diseases around the aorta. Well, that's not the case there. But this was a patient who was referred for retroperitoneal fibrosis because it was fibrotic material. This turned out to be that disease, Erdheim-Chester's disease, which is a totally separate disease, total separate therapy that does respond. But if we treated them like retroperitoneal fibrosis, they would die. Another example on the top, you can see this patient's actually upside down because they're getting a biopsy. And so now the spine is at the top as opposed to the bottom. But look at that kidney over on this side. You can see there's something infiltrating that kidney. And retroperitoneal fibrosis doesn't do that, but IgG4-related disease does. And so anytime someone is referred to me, now that I'm in St. Louis, I always ask for their CAT scan ahead of time. And the reason is not to be difficult, is that I don't want someone flying across country to see me when they don't have what they think they have. And I always rather have a good diagnosis before they see them in case they don't need to see me but someone else. And so if you refer to someone, they want to see the x-rays first, this is why. Because we can tell an awful lot just by looking at the CAT scan and maybe saving you a trip. So how do we tell the difference? Well, when we first saw these diseases, I biopsied everyone. I didn't know what it was. And these are very precarious biopsies because the needle has to go right next to your aorta. And if you miss by just a smidge, it doesn't always end well. So we biopsied our first 60 patients or so. And then we said we can tell this by just looking at the x-ray now what they have. But when we first started out, we didn't know. I mentioned before the location. Retroperitoneal fibrosis is from here to here. If it's up here, it's not retroperitoneal fibrosis, it's something else. And so if it's here, here, and up here, I can tell you this, it's IgG4 disease and not retroperitoneal fibrosis. We do measure IgG4 levels in the blood. Sometimes they help, sometimes they don't. But when they're sky high, they're very helpful. And at least alert us to the fact that maybe you should consider IgG4 related disease in this particular patient. And once again, the response to therapy. I mentioned to you before, people with IgG4 disease typically respond very, very quickly. And if that happens, I know it's not retroperitoneal fibrosis because that's over a year before I see that scar resolve. And I looked very diligently, even though I thought by x-ray it was retroperitoneal fibrosis. If they respond in 6 weeks, then I start to look for something different because I misread the x-ray or guessed wrong. But for the patient, that's good news. Pathology is very helpful. Now, I've made you all radiologists. Now I'm going to make you pathologists. You can see, I told you before that pink is bad. In this slide, purple is bad. Purple is inflammatory cells. And this is actually a biopsy of the kidney. And you should not see all that purple. So you don't need to be a pathologist. You see all that purple, that's really, really bad. On the right-hand side, these are cells stained specifically for IgG4. And so this is a patient with IgG4-related disease of the kidney. And sometimes we have to go to pathology and have the pathologist tell us exactly what's going on. I showed you the x-ray before of disease infiltrating the kidney. You can see all this mass right here. And unfortunately, given the fact that this kidney is outside the body, you know that the diagnosis wasn't made ahead of time. But this was IgG4-related disease, missed antemortem, and you can see how much the inflammatory cells invaded the kidney before death. I mentioned before that if it's up in the lungs or affecting the aorta in the chest, and this is a PET scan of a patient, and many of you may have had PET scans, and here you can see that yellow lighting up in the walls of that aorta. That's inflammation. Retroperitoneal fibrosis doesn't affect the aorta in the chest. And so when I see that, I know that this is likely IgG4-related disease and not retroperitoneal fibrosis. So symptoms, pathology, x-rays are very, very important. To give you an example, IgG4 disease also can recur very rapidly if you just treat with steroids. And so here's a patient who had IgG4-related disease. The drug was stopped in 2016 in December, and you can see by April, a very, very rapid recurrence of the disease. And so just as though it responds very, very quickly to prednisone, if you stop prednisone and don't use other drugs, it also comes back very rapidly. And this is another indication to us that it could be IgG4-related disease and not a retroperitoneal fibrosis. I mentioned Erdheim-Chester's disease before. This is a patient, I told you this was all the schmutz around the kidney. Now that you're all expert radiologists, you could all identify this. Unfortunately, this patient also died, and you can see this is all mass or tumor around the kidney. That space should be empty. There should be nothing there at all between the kidney and the outside of the skin. So it's very helpful to see where exactly the mass is and how it's affecting the patient. The pathology is also very different. And now that you're expert pathologists, I told you what color is bad. You can see here that while there's purple, there's this big white fluffy stuff all around the purple guys. You didn't see that before. And so this is an example of Erdheim-Chester's disease, and how pathology can stand out and really tell us which one it is. And when we started, we had no idea, because the pathologist would come back and say, well, some atypical cells here, we don't know what they are. And we said, well, we never saw those in our other patients of retroperitoneal fibrosis. What are these cells? And then we had to start doing stains that, quite frankly, didn't exist initially. And we had to retrospectively go back and try to figure out exactly what these cells were to help us figure out how to treat these patients. My task was to explain to you what I look for when I see a patient with retroperitoneal fibrosis, what are some of the common questions I get, and how we treat it. Now, what I was hoping to do is, for the rest of the time, is to answer your questions, because I had to guess what your questions were, but I didn't know exactly what they would be. So we have plenty of time, and I would love to hear your thoughts, your questions, or comments about your own experience with either IgG4-related disease or retroperitoneal fibrosis. Well, the etiologies are those two that I showed you. One was an immune response to the cholesterol in the aorta, and the other is an autoimmune disease to the vasa vasorum, or the small blood vessels that feed the aorta. We have looked at the genetics of those patients, and they have abnormal genes right next to the gene for lupus, and on a gene of the human body that's autoimmune in nature. So we think it's autoimmune in nature. What you see is a lot of circulating endothelial cells in the blood. I know it's getting very technical, but as the endothelial cells are attacked by either antibody, or I guess theoretically something could happen from trauma, those cells are circulating and the body is forming an immune response to them. I've had one or two patients that developed retroperitoneal fibrosis after an automobile accident. And the temporal relationship you can't ignore, but cannot always explain either. No, I think for IgG4-related disease, and we all treat it differently, and it's one of the reasons for this conference and other conferences that we've had through the years, trying to figure out what's the best treatment for IgG4-related disease. Certainly, the anti-B cell therapy like rituximab is very, very good, and the question is then, do you keep them on something suppressive for long periods of time? And everyone has a little bit different approach to that. And I think one of the reasons we have a lot of different experts here, like Dr. Stone and others throughout the country, is we get together to talk about how we do this. So not everyone does it the same way. But CellCept, I told you initially, we chose it for retroperitoneal fibrosis because it was the safest of the drugs that we use for immunosuppression. And so while it has some side effects, that are, women can develop, you have to be very careful about screening for, make sure their pap smears are up to date, because it's a virally mediated cancer, and CellCept interferes with your body's immune response to viruses. You could develop warts and those kind of things. For the most part, it's well tolerated. Certainly, IgG4-related kidney disease, most of the time we see it, you biopsy the kidney, it's very inflamed, you treat it with some drug, and what we're measuring is the creatinine in response to how well the kidney is functioning. We don't usually go back to rebiopsy the patient to see whether there's scarring there or not. Kidney biopsy in and of itself can be a very morbid event, and we don't do it willy-nilly. So I can't answer the question because we never went back and biopsied those kidneys again. Yeah, so the challenge there is, if unlike the tissue around the aorta, has no function, right? That's just added on there, then it does nothing. When something destroys an organ like the kidney and destroys the functioning machinery of the kidney, even if you were able to get rid of the scar tissue, the functional machinery is not rebuilt. We've had a lot of misreads. I was in my office one day and my secretary said, there's a doctor on the phone who wants to talk to you about your protocol doesn't work. And I said, oh, this ought to be good. So I answered the phone and he was actually a nephrologist himself who was diagnosed with retroperitoneal fibrosis. But as I talked to him on the phone, he had a lot of fibrosis up and around his heart and around his lungs. And you all can probably make the diagnosis now that that's not retroperitoneal fibrosis. And he says, well, when they tried to do my bypass, they did pathology specimens. But I did go to the pathologist and said, did you consider this? And he had not. And when I said, I'm worried about this, he did the special stains and proved that's exactly what it was. And so not only does the pathologist have to be able to read the specimen, there has to be communication between the doctors as to what they're looking for. Because if the pathologist doesn't know that you're looking for something, they're not going to stain for it. And so it's not always the pathologist's fault that the diagnosis doesn't come back correct, is that no one told them to look for it or what they were concerned about. If someone is obstructed like you were, obviously you have to search for the cause of that. And there's a number of ways to do that outside of just taking out the kidney and the ureter. And so that would have been the focus of what we would have done, is try to figure out what's causing the obstruction. And we've been as invasive as we needed to be to figure that out. If someone comes to me and says, I have back pain and I get a CAT scan, it's totally normal, I may have missed it. But we also look for things in the blood. Is there inflammation? And not necessarily just IgG4 antibodies, but SED rates, CRPs, are they anemic? When you have a lot of systemic inflammation, your red cell counts go down. And so there are the other things that we'd be looking for to try to figure out whether there's systemic inflammation as the potential sign of what's going on here. I prefer a CAT scan, and that's maybe because I can read them better. I think if you're a radiologist, they're going to tell you an MRI is going to be better. But if I'm reading it, I prefer a CAT scan. As you know, for a CAT scan, you're in and out in about 2 minutes, or an MRI, you're in there for 45 minutes. And if it was me, I'd rather have the CAT scan. It's not something that most nephrologists ever get in their training. And so unless they're at a center where they see a lot of it, most physicians will not have a clue, and gets bounced back and forth between vascular surgeons who says, I don't know what this is, but there is no spaceologist. And that's been the problem all along. But it's been, for me, fascinating to discover 3 different diseases and figure out the treatment for them. Now, I've typically, since we didn't know, I was treating IgG4 before rheumatologists owned the disease. So I still treat all my own patients. And because it's a rare disease, most patients don't come from where I am. And so, for instance, if they have IgG4 related disease and they need rituximab, I do refer them closer to home, not because I want someone else to manage them, but I don't want the patient to travel to St. Louis for their infusions. And so in those situations, I try to find a local physician who is willing to collaborate with me on those. I think the difficult part is when it only affects this area, and IgG4 only affects that area. And so they can mimic each other. And that's what was so confusing early on, is that why some subgroup of patients responded very differently than everybody else. And, back then we didn't have the ability to stain for IgG4. And so in retrospect, why didn't you stain for it? Well, we didn't have it. And so it wasn't until some of these, later developments occurred that we were able to try to differentiate between the two of them. And then, Dr. Stone and a group from Japan really took over all the leading research and really discovered that, using things like rituximab were very, very helpful. That's never something I used before Dr. Stone told me to do it. Well, the 3 diseases that can present just with that mass around the aorta are the three that I mentioned. Retroperitoneal fibrosis, IgG4 disease, and Erdheim-Chester's disease all can initially present just the same way. And we have to go through the mental gymnastics of the differences between the three from a symptom perspective. For instance, Erdheim-Chester's causes terrible bone pain because it affects the long bones as well, and affects a number of other organs like the brain and et cetera. So we have to do the mental gymnastics and ask the patient, are you experiencing these things, and what helps us go in a certain direction? I think if someone presented with, say, pancreatitis and retroperitoneal fibrosis, I'd be very suspicious for IgG4 related disease because it is a disease that known to affect the hepatobiliary system. We mentioned about lung nodules or disease in the chest. There are other kind of things that make me think about IgG4 over retroperitoneal fibrosis, but if none of those things are present, then there's nothing that helps me distinguish because the symptoms can be the same. So if there's nothing that helps me sway what it is, I typically default to use our protocol, prednisone and CellCept. And one of the features that may tell me that it's IgG4 is that's totally going by the 3 months CAT scan that I got. And so that alerts me and say, maybe I didn't quite have the diagnosis right. They're better, and that's good. But I also then have to say, well, this person is going to relapse when I take them off the drug, and maybe I need to consider rituximab. Certainly, we teach residents and new doctors all the time. The real difficulty is trying to get someone to follow your footsteps and dedicate their entire career to these diseases. And there's not been a whole lot of people who stepped up to the plate and said, this is what I want to do with my life. And, I'm on the verge of retirement, and I can't say there's someone right behind me to pick up the pieces. One thing you don't want to do is you keep getting CAT scans every year just because of the radiation issues. And so if people are symptom-free, remember, they came to me for a reason to begin with. They had symptoms. And so if you're symptom-free and your lab tests show no evidence of anemia or an elevated SED rate, that's all I look at. The symptoms are the important things. Patients know when they're sick again, long before I ever do blood test. Well, I think, we've understood a lot in the past 25 years, but there's still a lot we don't understand about the pathophysiology. I told you there's several different possibilities. We have no way to figure out which one it is in any given patient. I'm sure there's probably a lot more mechanistic things that we need to understand. We were just lucky that a very non-toxic drug worked, and the burning platform wasn't as severe as it was early on because you had a therapy and patients got better. I think it's one of the benefits of getting to know your patient. So, it's easy to say, patients call you up and say, well, I have a little twinge. And I say, well, let's go back to when you presented. Remember, this is how you felt. You described the pain as 10 out of 10. That's not what you're telling me now. What have you been doing this weekend? I was mowing the lawn. And so the more you get to know your patients, the more you can do those, try to sort out those little things, one versus the other. But it's not perfect. The time is here. I'm supposed to remind you to go to the first floor into the courtyard for a group picture. Thank you very much.